Hello everybody, welcome again to another edition of the MCHD Paramedic Podcast. If you're joining us on YouTube, thanks for watching. If you're listening, as always, thanks for listening. Joining me today is our Quality Chief, Kevin Crocker.
Hello everybody.
And today we're going to present an abstract that we submitted and presented at the National EMS Physicians meeting back in January of this year, which after COVID and the comings and goings and comings and maybe goings again of the pandemic seems like ages ago.
So long ago.
But we were proud of this data and really think there's some timeliness to it. So while it's a little bit delayed, we still think it's appropriate, and hopefully this maybe, I don't know, maybe prod some folks along to think about this medication and think about its use in EMS. We feel like it's been a really excellent addition to our toolbox here at MCHD, and what we're going to discuss is our experience with IV acetaminophen, IV Tylenol, trade name Offermev. We've been using it here at MCHD for a couple years now for both pain and for antipyretic uses for our febrile patients, again in IV formulation. And we're really pleased with how this has worked. Our medics really like it. The specific data that we looked at was some pain data, but before we get into the data, you know, where did this protocol start, Kevin? Why did we decide to implement it? You know, where was the kind of the genesis of this?
Yeah, so that's a great question. So you have to go back pre-COVID, so way back. I think it was probably 2016, 2017, we kind of started looking at alternate options that were not opiate based. Back then the opiate epidemic was a really big topic, and it's still a topic today, but not as much as it was back then. So we were looking for a non-opiate based pain management option for our providers to use. Really with the goal we thought at the time we were looking was to find an option that would reduce our opiate use. Offermev had some promising pre-hospital data. There wasn't a whole lot of pre-hospital data at the time, and the ones that were international. We couldn't find a lot of US-based studies that talked about using IV Tylenol in the pre-hospital setting. So the data we looked at was very promising, so we decided we would give it a shot and kind of implement it here at MCHD and see how it went. We initially, like you talked about, we deployed it for pain management, but we also opened it up for sepsis. So if you had a septic patient who couldn't take IV Tylenol PO, we opened it up as an option for that as well. We thought that, initially going in it, we thought that our providers would probably use it for what they perceived as less severe pain, so they'd still use the opiates for their severe pain, but they would use it more for what we thought would be the less severe type of pain. And that's kind of how we got started with the IV Tylenol here at MCHD.
And so just to piggyback on a couple of points you made there, this is, this IV formulation of acetaminophen has been around for quite a while. Prominent use in operating room settings, especially in Europe. It garnered some press probably 15 years ago, but the big limitation in America for a long time was cost. And realistically, I don't have access to IV Tylenol in a lot of my EDs just based on cost alone was the big concern. And the idea that, a couple pennies for a dose of morphine or a dose of fentanyl, whereas, at one time, this was in the hundreds of dollars a dose. We now source this at, last I checked here at MCHD, was $40.
Good news for you.
I actually talked to someone who procured it from another agency this morning, and we're down around $8 a dose.
Okay.
And
yeah.
maybe even less than that coming soon. The real reason why we wanted to get this out today was that this is going generic in June. It sounds like it may be already headed that way now. So the cost should keep going down. And again, the opiate epidemic, thankfully, has spared us a bit here in greater Houston, especially on the north side. We don't see as much opiate issues as we do, in the Midwest, especially, Ohio, Indiana, Kentucky. I trained in Indiana, I'm from Kentucky, and both of those spots were really hard hit. But that said, it's still an excellent hemodynamically neutral, non-sedating pain option. How does our protocol read? Who gets IV Tylenol? What's the dose? What are our contraindications?
So we left our protocol pretty broad. So we didn't give specific targeted treatment of if you have this type of pain or if it's at this number on the pain scale, give this medication. So we left it more to provider discretion. So if the provider thought that the patient was a good candidate for IV Tylenol, we left that decision in their hands. So we did it two ways. So we did it for pain. And pain we did for both medical pain or traumatic pain. So no matter what the origin of the pain was, we left the provider discretion to treat that pain as they saw fit. And then, like we talked about earlier, we also thought it was a good option for fever reduction and sepsis. We know we have a lot of septic patients here at MCHD and in the U.S. in general, and a lot of those folks are altered and they can't take oral Tylenol. So we added it to our protocol to treat oral Tylenol as well. As far as dose goes, we give 1 gram for adult patients, IV over 15 minutes, and pediatric patients get 15 milligrams per kilogram, same IV over 15 minutes.
So for all the listeners out there that are concerned about complexity here, 1,000 milligrams or a gram and 15 milligrams per kilogram is the same dosing for oral Tylenol.
Yep.
So there's no learning curve there. In our protocol, did we list specific contraindications?
Yeah, so we listed a couple, not a lot. So the first was if they had an allergy, a known allergy to Tylenol. Clearly that's the obvious one. The second one was that they had some kind of liver disease. We know Tylenols can be hard on the liver, just the way it's metabolized. So if we had a patient who had a known liver dysfunction or liver disease, we made that a contraindication as well.
So the beauty here is, we have other non-narcotic medications in our toolbox, specifically ketorolac or Toradol, which is an NSAID, an excellent, musculoskeletal pain medication, excellent for kidney stones. The downside there is that it is a reversible platelet inhibitor. So if a patient potentially has operating room in their future or has potential ongoing bleeding, subarachnoid hemorrhage, traumatic brain bleed, liver lac, spleen lac in a trauma patient, the traumatic patients and the potential OR patients are really not going to be candidates for ketorolac or Toradol, whereas Tylenol has no platelet effects. So that group of patients is entirely on board, entirely a good candidate for IV Tylenol or Offermed. So it fills a gap, it fills a need there, and we're not going to sedate the patient, we're not going to cause respiratory depression, we're not going to drop the blood pressure with it. I've seen some studies recently that have looked at, comparing IV Tylenol, I'm not trying to steal your thunder here, to narcotics, and some ED studies that show maybe not quite as good pain control, but
yeah,
realistically, what would you expect?
Right.
Would you expect Tylenol to be stronger than Dilaudid, even
No.
in IV form? Probably not. But let's get into our data a little bit, because this is where, I feel like the abstract was pretty powerful. You led the abstract submission for our IV Tylenol data. What were you looking for, and what did we find, and how was this pretty encouraging to us, really?
So for us, the genesis was the pain piece of it. It wasn't the fever reduction, the sepsis. So everything we're going to talk about data-wise kind of focuses around the pain management side. So that was kind of our starting for the research project, is how does it do with pain? So we really had a couple questions going into the research abstract, and it was, does it reduce pain? We didn't know that. Clearly we assumed it probably did reduce pain, but we didn't know that for a fact. So that was probably one of the primary endpoints of the study was, does it reduce pain? Second, anytime you do a research study, you should always look at the safety of it, right? Is it safe to administer? Do you have any major side effects associated with it? Just the safety profile of the medication in that setting was the second. And the third, and we kind of knew going into it before we even rolled it out that it probably wasn't going to be opiate sparing based off some of the other data we had read. But we were just curious, did it have an opiate sparing effect in our system? Those were kind of our initial endpoints that we were going to measure. So we did a total of 10-month study. It was 10 months of data that was inside the abstract that we submitted. How it worked, or how does it reduce pain, we kind of came up with a definition based off some other research we had read of clinically significant pain reduction. And the definition of clinically significant pain reduction that we used was a reduction of at least 2 points. So on the traditional pain scale of 0 to 10, if their pain was reduced by 2 points or more, we call that clinically significant reduction in pain. Safety measures, we looked at side effects or significant side effects, and we called that nausea, vomiting, or allergic reaction. So that's kind of the setup of the study. Inside the study, we ended up giving 215 patients IV Tylenol for pain. So that was our study group. a little bit surprising to me. We used IV Tylenol more in medical pain than we did in traumatic pain. That was a bit of a surprise to me. About 65% of the uses for pain was for a medical etiology of pain, and the rest was for traumatic pain. The initial median age group, or I guess the total median age group, was 56 years of age, which is a pretty good representation of our patient population. It's about what you would expect in our service. And 62% were females. So it was a little surprising. Expected probably a little more on the male side, but 62% were female. The median initial pain score. So when we showed up and said, I see you have pain, what's your pain, 0 to 10? The initial median score was 8, so it was pretty high. It was a little higher than I thought it was going to be, because like I said early on, I thought that we'd probably use the IV Tylenol more for a lower pain group, but the initial score was 8. And after they received their dose, so the last pain score before we dropped them off at the hospital was 5. So we had an average reduction of 3 points with the IV Tylenol, which was super promising to me. I don't know if I expected that or not. It's a little more than I probably thought it would be, but I think that's a huge success for the medication. In addition to that, we had no side effects. So nobody of the 215, none of them had any, documented nausea, vomiting, or allergic reactions. So, the third endpoint, the opiate sparing piece, is kind of what we expected going in. We're a big service. We treat about 60,000 patients. So clearly giving 215 doses probably didn't have an effect on our opiate usage, and it didn't. We used about the same amount of fentanyl in the pre and post, because we did look at that. So we didn't find an opiate sparing effect here in our service. And there's probably a couple reasons for that. I mean, we could probably do more to target patients and say, and write a more specific, strict protocol, but we didn't do that for this study, and we left it more to provider discretion. But I don't see that as a failure. I think for us, the primary endpoint of this was, does IV Tylenol reduce pain? And I think our study says it does.
And safely is a key here. To be honest, when you brought this idea, we were doing our abstract sort of brainstorming probably this time last year, probably about a year ago to today-ish. You brought it up, and I said, yeah, let's look at it. Let's see what our pain reduction was. It all stemmed from the easiest data to mine and some simple points, and we thought this would kind of fit the bill. But we didn't really do any kind of, this was word of mouth. This wasn't a whole lot of advertising. We did not, we rolled this protocol out, and we obviously educated on it, but we didn't put a IV Tylenol first, opiate second. We really just kind of rolled the ball out on the court and let people pick it up and play without a whole lot of rules.
Yep.
And I honestly, when you think about 200 plus doses in 10 months, that's almost a dose a day.
Yeah.
That was probably more than what I expected on an overall just pure usage scale. So I was really pleased with that. I probably was a little bit shocked that it was more medical than trauma.
Yeah.
But again, we didn't push it one way or the other. This was sort of the natural progression within the service. We talked a lot. You mentioned it a couple times. I mentioned it. IV Tylenol may not be opiate sparing. We found the same thing. But in all honesty, I think if we pushed it the right direction and we restructured our protocol, and you really wanted to go that direction, I think we probably could with equipoise. How do you feel?
I completely agree with that. We didn't do a deep dive into the fentanyl administration we had during that time period. So I don't want to say that fentanyl was better than IV Tylenol or IV Tylenol was better than fentanyl, because I don't know those numbers off the top of my head. But a 3-point reduction, I think, is huge. It's very significant. And I bet if we did go back and look at the fentanyl, it's probably about the same, probably a little better, right? Like it's a better, we know that opiates treat pain probably better than IV Tylenol does. But I bet if we looked at the pain score numbers, there's probably not a huge difference. It's probably 4 or 5 points on the fentanyl side. So I think if we did go back, or if we started today a new research project and we looked through those 215 patients and we dug into that data and saw the patients that it worked the best on, we probably could start targeting other patient populations and increase the use and make it more opiate sparing.
And realistically, that's what the ED and hospital data have shown.
Yeah.
I mean, if you look at, there was a IV Tylenol versus hydromorphone study, I believe, that was in the past year or so. And shockingly, Dilaudid controls pain a little better than IV Tylenol does. I don't know who would
Who would've guessed that?
Who would read that and be shocked? That said, the IV Tylenol still controls pain pretty well. So it's not about, in my mind, it's not about supplanting the use of opiates. If I have an open femur fracture, give me fentanyl, dilaudid morphine.
Yep.
I want some good narcotic pain control for that.
Absolutely.
To this day, I don't feel like there's data there that says that's the wrong thing to do. Now, if my blood pressure's 70 and I've got potential liver lack along with my open femur, maybe the better option is IV Tylenol and IV ketamine.
Yeah.
Together.
Absolutely.
That's another discussion that we've had around here. What if you paired IV Tylenol and ketamine and compared those to opiates? Would you be equal there?
I bet it'd be very similar.
Or even better.
Yeah.
So it's all about giving our medics the best options in specific circumstances, and realistically a hemodynamically neutral, non-platelet affecting pain medication is something that we really don't have besides ketamine. And the advantage with IV Tylenol as opposed to ketamine is you're not going to get any of the dysphoria that you may get with ketamine. Even though it's not super common, it does occur, and sometimes people don't like how IV ketamine makes them feel. Even if you stay in that 0.3 per kilogram, pain control analgesia range, there's still a risk of people, even if it's not full-on dysphoria and emergence, sometimes people just
Get a little loopy and they
just don't like it.
Yeah. I like the analogy of like a carpenter, right? A carpenter doesn't bring just a hammer to your house to fix something that's broken. He brings the whole toolbox. You don't always need a hammer. Sometimes you need a screwdriver or pliers. And, I think we need to be, like as a profession and as providers, like we need to have more targeted tools in our toolbox to give our patients. So not every pain needs an opiate. There are other options you can use. And when you expand your toolbox and put things like IV Tylenol in your toolbox, I think you open up your options for treating your patients, and you kind of give your providers a little better options to make sure they are targeting the right medication for the right patient.
And on that note, we mentioned it before, but going generic now.
Yeah.
So really that's the reason for our discussion today, is that if you're listening out there and you've been avoiding IV Tylenol for any time period based on cost, I would advise you to call your reps and your distributors and your folks up and reprice this, because it's coming down into a range where it's still more expensive than opiates, but in the right patient population, when you can spread it over from both pain and antipyretic uses and use it in those febrile, altered septic patients, it makes a pretty good fit. You can make a much better argument for it at $5 a dose than you could at $80 a dose.
Yeah.
That's the gist of our current data set. While we wrap it up, talk about the future. We presented this in an abstract form at the National EMS Physicians Meeting just this past January. Where do you see our data and our work going? Do you see IV Tylenol expanding within EMS? Kind of wrap us up with how you think this may go in the future, Kevin.
Yeah, I think there's a couple points there. And COVID did kind of put a roadblock on a lot of our research projects here at MCHD, and IV Tylenol was a victim of that. I think there's probably two things we could do. We kind of talked about one already. So if we looked into our data and we kind of looked at which pain, was better affected by the use of IV Tylenol, and making a more structured protocol that was more targeted to that patient population, I think we could probably do some better analysis and probably some better treatment of patients if we dug into that and made a more targeted approach. Second, and probably this is I don't know if it's the most surprising, but it was one of the more surprising things about the data. We had 215 patients who got IV Tylenol for pain. In that same 10-month time period, 313 patients got it for fever secondary to sepsis. And I did not expect that when we rolled it out. So it was a much higher number. And we didn't do in-depth data collection on that because it's harder, right? Like that's a hospital included study. The pain management study we did just did a initial pain score and a final pain score. So it was easy for us to get the data. If we were going to look at, does IV Tylenol, improve the mortality or shorten length of stay for patients who are septic? That's a hospital-involved study where we have to go and get the ICU length of stay and intubation numbers, and their initial pain, initial fever upon arrival. Like, that's just a more in-depth study, so we didn't do that this time, but I think in the future we could look at that, because there may be benefits to those patients getting early IV Tylenol in the pre-hospital setting. We just don't have the number for that today, but I could see that as being a research project, either here at MCHD, or if there's a listener out there who has a service that kind of wants to take that up and run with it, I think that's a great opportunity for future research.
And there are folks out there, there is a camp, and there are believers out there that potentially treating fever and sepsis may not be ideal. So the other side of that coin may be, is there detrimental effects to treating,
Of course, yeah.
to treating early septic patients, to treating their fever. So that would be where I would want to take it. Of course, I always want to take it where we need hospital data, and that always ends up in the pain of going to all 7 of our receiving hospitals and dragging data out of folks who I know hate to see me coming. So we'll see where that leads. Kevin's over here cringing.
Our great hospital partners who are always happy to help.
They are, but
It's
they,
just,
they do hate to see me coming.
it's a
because
process.
It is,
Yeah.
you know, it's hey, we need 20 patients from 8 months ago. What was their length of stay? What was their blood pressure on arrival? And you've got these data collection sheets, and we all know the state of the hospitals right now, and everyone's overwhelmed and understaffed and trying to fight through the end of this pandemic. So I understand that I'm causing pain with these questions, and so I appreciate all of our receiving hospitals' help, and everyone is always gracious in providing us with feedback and outcomes. So I can't be more thankful. I understand how annoying it is to get an IV Tylenol question 18 months after the fact. Like, what? Why do you need this now? What are you doing? So I get it, and I promise we're not going that direction anytime soon. But I would agree that would be interesting to see the effects of IV Tylenol early in those septic patients, and looking at ED markers, hospital markers, the flow of those patients compared to standard treatment, and rectal Tylenol or oral Tylenol once they get to the ED. Is there any benefit there? Is there any harm there? It would be interesting to look further. So that gives us a good spot to wrap it up. Anything you want to add?
No, I think that's a good place to end it, but I would say that if you haven't looked at other options for pain management, you're just using opiates, there are other options on the market. IV Tylenol happens to be, in my opinion, a pretty good one. So if you're in the market for shopping for something, I would definitely look at IV Tylenol.
And as always, if you have any questions about anything that we've used to teach the pharmacology and use of IV Tylenol in our service, we're always happy to share. If you have questions or ideas for additional podcasts, hit us up at the podcast email, podcast@mchd-tx.org. Please leave us a like or review wherever you listen to your podcast. If you're watching on YouTube, we love comments on our YouTube channel as well. Thanks for joining us today, Kevin, and putting our data out there. As always, thanks everybody for listening and watching, and we'll talk to everybody again soon.